Okay. So, as you all know, this session will be focusing on accessible healthcare. I think it's safe to assume that many of us have a sense of what good healthcare is and how that's carried out. The challenge is providing that healthcare for everyone. So this session will be focusing on that topic, as well as looking at how philanthropy can promote accessible healthcare and how the three sectors that we heard about from Anders Aslund and his Social Welfare Society can work together to do that. We have a wonderful group of panelists here, each of whom has unique experience on this topic of providing healthcare for everyone. I won't go into details since you all have their biographical info in the booklets of the conference. But we'll hear from each of them in turn, and then we'll open up the floor to questions so that we can all engage in conversation with everyone. I'd also like to make sure we remain mindful of the time so that each of the panelists has the opportunity to talk to us about their experience, but we also have time to engage everyone here in conversation. So without further ado, I'm handing it over to Dr. Pierre Barker to start us off.
Thank you very much.
First presentation, thank you.
Yeah, thank you very much, and thanks particularly to the Stavros Niarchos Foundation. It's a great honor to be here in Athens and to have an opportunity to talk about this important topic. The title of my talk is Rapidly Scaling Up Health Programs in Poor Economies, and I do want to lay out a case for a system of improving care in poor economies, but also, very importantly, what the role for philanthropy might be in that. Just very briefly, I work for the Institute for Healthcare Improvement. We have a very bold and broad mission and vision. We're hoping that through our methods we can improve healthcare around the world, and our vision is that everyone has best health, best care and health possible. We're very small, we're 140 people, and the way we can work is because we work through partners. We have partners in multiple countries around the world. And it's through these partners who adopt the methods that we promote that we believe that we can really have a very significant impact. A very important partner in our program are the funders. And so I'm hoping to be able to show how a small amount of money can go a long way in really having a major impact on healthcare. As I say, we work around the world. IHI started about 20 years ago working primarily in the United States, but we have large programs in Europe, in Africa, and we also work in Latin America and the Pacific Rim. We're known globally mostly for our work on hospital safety, but we also work in population health. We spend a lot of time transferring this system of work, which I'll describe, into our partners. And more recently, there's been a strong focus on patient-centered care. We're known as an organization that innovates. We're also very focused on large-scale results, really having impact at scale. And we're also very focused on ways of getting this message out. So we have an open school, which is an online learning for the methodology that we use. About 150,000 people signed up, and it's mostly directed at medical students and nursing students and doctors in training. So without any further ado, I'd really like to take you to the West African country of Ghana, to a very rural setting. And in this dwelling, in this group of homes, is a 20-year-old mother. It's her first pregnancy, and she has just gone into labor. And she knows that she has to get to a health facility, but before she can set off, she has to get hold of her husband, not only to help her get there, but also to get permission to leave the compound. So somebody goes off, he's working in the fields, there's a couple of hours elapse, and he comes back. But it's not that easy for them, because the next obstacle they face is that in order to get out of the compound, they also have to have a discussion with the chief. The chief has to make a decision as to whether or not the mother can go to the facility or whether she can receive care more locally. And all of this, I'm telling you this because this mother hasn't even got out of the house yet, and already there are complex social factors that have a profound effect on the likely outcome of this mother, or in the case of a sick child, who would have to have the same kind of permissions in order to be able to leave the compound. What you see here is three conditions. Either, and this was a study that was done in exactly that area where I showed you that photograph. So if the mother doesn't have to leave, doesn't have to get permission from her husband, there is a death rate of about 60 per 1,000 infants. If she has to get permission from her husband, it goes up to 80, and if she has to get permission from her husband and from the chief, it goes up to 120. So you can see just this obstacle of decision-making, whether or not the mother is empowered to make a decision, has a tremendous effect on outcomes. So when we think about access, it's not just hospitals, training, and doctors. It's complex social environments. So this mother now has another obstacle that she has to overcome, which is how she's going to get there. In the case of this village, the only way to get to the health facility, which is about 20 kilometers away, is on a bicycle, because no one has any motorized transport. And typically a mother like this would go on the crossbar of a bike, cycled there by her husband. When she gets there, she'll encounter a nurse who will be well trained, and a lot of IHI's work is done at the site to make sure that with the limited amount of resources available, that care is delivered very reliably. And what the purpose of showing you this slide here is really just to show you how few commodities or resources you need to deliver great care. So we're able to ensure great. So this is a graph here, which is the nurse records the progress of the mother's labor. Here you see at the bottom the otoscope, the instrument that is put on the mother's abdomen to listen to the heartbeat of the child, and the blood pressure monitor. So I can't tell you the outcome of the specific mother, but I can tell you that on average she probably would have survived. But there's a very, very scary statistic that mothers and babies have to live with in this part of the world, which is that over a lifetime, a mother has a 1 in 40 chance of dying. So 1 in 40 mothers will die at some point in their life giving birth, and some of these mothers will give birth 4 or 5 times. But that's a terrifying statistic if you think that losing a mother's life in childbirth is a rare and catastrophic event in high-income economies. The risk of the newborn dying is 1 in 50 every time. So every newborn has a 1 in 50 chance of not surviving, which again would be very different from what we would see. So the scale of the problem is huge. But there is hope, and it's encapsulated in the statement which was issued at the African Academy's meeting in December 29. So the statement, and I'll read it: 4 million women, newborns, and children in sub-Saharan Africa could be saved every year if well-established, currently available, affordable healthcare interventions could be implemented across this region. What this means is we have the knowledge and we have the resources, but we don't do what we know. Even in these economies, there are sufficient resources and there is sufficient knowledge, but it's not practiced. The conclusion of a statement like that is that we can do better today with what we have already. We don't, while we should be advocating for resources, good policies, and training, we seem to have got stuck on this. We seem to, particularly around the training seems to be the reflex response. If a system is not working, we do more training. We have the knowledge. The WHO has done a beautiful job in providing us with guidelines and policies about what to do. And in fact, while we do need resources, and often resources are an obstacle, there by and large are sufficient resources to be able to do this. So what's missing is functional systems. And that's what our work is. We believe that if you can redesign systems with the resources that are available, it's possible to get a much better result. And I love this statement which was first made by Paul Batalden from Dartmouth, who said, every system is perfectly designed to achieve the result it gets. So it's no accident that there's a traffic jam at the end of the day, and there's no accident that there's a traffic jam at the beginning of the day, because we design our lives to start at a time and finish at a time. We build more roads, which will build more cars. We have designed this traffic jam, so it should be no surprise that there's a traffic jam. In the same way, when we get a bad result in the health system, it's because that is the result that system is designed to produce. And the primary way in which we can change that is by changing the design of the system. So I'll use this motor car analogy. In 1970, 2 cars were built, one in the United States and one in Japan. The Ford Pinto in 1970 now has the dubious reputation of being the worst car that was ever built. Okay? The Toyota Corolla, on the other hand, also built in 1970, went on to be the most successful single car that was ever built. And what Toyota understood, there were many reasons why Toyota built a great car, and there were many reasons why the American industry reached such a low point. But one of the important lessons that we can take away from this example is that Toyota understood that great ideas were at the front line. They allowed their production line staff to stop the assembly line if something was going wrong, and they sourced most of their great ideas for improving the design of their cars from the front line. And that's the basic philosophy that we use, that there are great ideas, a tremendous unused resource at the front line, which we certainly can do. So let me take you through what typically happens. So if we encounter a problem, and this is pretty widespread, somebody in leadership will come up with a solution. That solution will then be passed down in order to be implemented. But the problem is that it'll almost certainly hit some unforeseen system barrier and fail, and certainly it'll be very difficult to spread and implement. We believe there's a much better way to solve this, which is that we can take that problem right to the front line, where the people at the front line, if you give them the understanding about the system, you will be able to pull from them the great ideas that are required to solve that problem. But not every idea is a great idea, so we have to put it through a disciplined, rapid test cycle, which if it survives, and if we can measure that it actually leads to an improvement in a system, we have a much better chance of it being implemented and spread, because these are ideas that are context-specific. So you cannot take an idea from Athens and take it to Luanda and expect it to have the same effect. These ideas for implementation have to be developed locally, and most of the people at the front line actually already have great ideas as to how to do it. The other big problem that we have with access is linking the communities to the facilities, and I know we're going to hear a little bit more about this on the panel. But there are really very few great ideas about linking communities to the facilities. Typically, the work happens at the facilities, and the ideas are imposed on the community from the facilities. So we've taken a different approach, and we'll speak about 2 examples. This one is in Ghana, where we mapped the community. We found out who are the key stakeholders who are involved in solving the problem. The problem is, how do you get a pregnant mother from her house to the facility? How do you get a sick child from a house in a very difficult situation to the facility? So we went out, we mapped the community, and we actually brought all the representatives of all the key stakeholders and got them to understand the system, got them to map the system, and got them to come out with the best ideas. Likewise, in Malawi, we actually formed a link structure that was composed of the village representatives, traditional leaders, and healthcare workers. I want to draw your attention to one of the labels on the slide, which is funder. The Health Foundation funds our project. It's a UK charity, funds our project, and is very deeply involved in this project, to the extent that their project officer there, sitting in the middle, came with us to experience what was happening in the field. Some of the ideas, and I showed you the alternative before, which was sitting on the crossbar of a bicycle. The villagers got the resources together to buy a a bicycle ambulance. About $150 will buy you a bicycle ambulance. 6 villages together, clubbed together to buy this bicycle ambulance. In the more urban setting, the taxi driver who you saw in the previous slide made a suggestion, which is, I will take a pregnant woman for free from her home to the facility if in return you will allow me to put my taxi at the front of the queue to take paying passengers back. So these are simple ideas that came out of the community. And the chief who had stopped who potentially could stop the mother became one of our biggest allies, and he started fining the mothers, and this wasn't an idea which I particularly supported, but he started fining the mothers who didn't go to the health facility and were delivering more locally. This is my only data slide, which basically shows the tremendous effect that these community groups can have. This is a community where none of the newborns were being screened at the clinic, and you can see the effect that pretty much all of the newborns were able to be seen at the clinic. I just wanted to end with this statement about the role of philanthropy. In pretty much all of our large projects, we work together with a funder, together with the private sector, which is mostly non-profit NGOs, and with the government. In the case of Ghana, we're working with Bill and Melinda Gates Foundation, the National Catholic Health Service, and the Ghana Health Service. The funder, the Gates Foundation, asked us to see if we could help solve 3 questions. One is whether we could use this methodology to help Ghana get to its Millennium Development Goals. Secondly, whether we could use a large networked NGO like the Catholic Health Services as a platform. And thirdly, could we use the innovation space that could be created by this combination to do something very different and to be able to scale up. Now, we could have never gone to the government to ask for this innovation space. It's a unique role for the funder. I don't have time to take us through the phases, but there is a science behind demonstrating, innovating, and rapidly scaling up, rather than a blueprint where you just suddenly roll everything out. And certainly working together with the funders, we can achieve that. So I wanted to end with 3 key ways that I think that philanthropy can help solve access to care. Firstly, we have to get out of the policy, resources, and training mindset. There is another way to change systems, which is to redesign them using the resources that we have at hand. Secondly, insist that the projects that you fund go to scale. There are so many pilots that are wasted money that have gone nowhere. Insist that the design of the project goes to scale and has scale and sustainability in mind. And secondly, don't underestimate the power of philanthropy. You can change the world by applying your resources in this very leveraged way to get great results. Thank you.
Thank you, Dr. Barr. So we'll hold all our questions until the end, after everybody speaks. Dr. Friedman?
Thank you. Is this...
They will open the
Thank you, Rula. I too would like to thank Rula, Andreas, and the Foundation for the invitation to speak to you. In my 10 or 12 minutes, what I'd like to do is demonstrate that accessible health care for all is not a pipe dream, but is indeed a possibility. And I'll do that first by giving a little background information, and then actually comparing healthcare systems in countries that do it well and healthcare systems in one country in particular that does not do it well. And I think by comparing and contrasting, we can come up with a blueprint for how to develop healthcare systems. The year 2000 is a good place to start. It was an exciting year for many reasons. Mankind had survived another millennium. That's always an exciting event. In addition to that, the World Health Organization came out with their annual report in which they actually ranked the healthcare systems of all of their member nations. And this shocked and dismayed a lot of people. You can see that France and Italy did very well. They were in the top 2 spots. Greece did pretty well. Switzerland was number 20. And I remember when I looked at this report, I kept going back to the top to find the United States. And after going back and forth 3 or 4 times, it dawned on me that maybe I should look further down. And there at number 37 was the United States. I mentioned that the World Health Organization comes out with an annual report. These are some of the subsequent reports that they came out with, always on issues of global health significance. Interestingly, in 2010, the title of their report was Universal Health Care Coverage, which is essentially what we're discussing today. I recommend this report to all of you. It's available online. It's about 100 pages long. And the report starts out with something I think we can all agree on, and that is access to basic health care is a fundamental human right. And what we're trying to do today and in the future is translate that right into a reality. The report goes on to suggest how countries can modify their financing systems to move towards this goal. It provides an action agenda for countries at all stages of development. And it also calls upon the international community to support efforts in low-income countries. Now, that report was criticized by many people because it relied very heavily on literacy rates and mortality rates. In 2010, the Commonwealth Fund came out with their own report, and they said we need some metrics that better assess healthcare systems and performance. And they determined that quality, efficiency, access to care, equity, and by that I mean people with chronic conditions but low incomes can continue to get care, and finally the ability to lead long, healthy, productive lives are the hallmark of a well-functioning health system. And they looked at 7 pretty well-to-do countries, and once again the results surprised many people, particularly in the United States. And that's not a typographical error, the small font. As you'll see in a minute, the US performs nowhere near in the category of the other 6 countries. When we talk about quality, US patients were more likely to receive wrong medications and experience delay in receiving abnormal test results. When we talk about efficiency, half of Americans with chronic conditions have difficulty obtaining a recommended test or follow-up. In the Netherlands, that number was 7%. In terms of access, 1 out of 5 Americans with chronic conditions go to an emergency room because an MD is not available. In Germany, that number was 6%. When we talk about equity, again, about half of American patients with chronic conditions and low income go without needed care. In the Netherlands, that number was 4%. And finally, the US was last in infant mortality and preventable deaths prior to age 75. The numbers get even worse. In any consideration of health care, we have to talk about money. And the per capita cost in the US in this report was $7,300. It was 16% of GDP. You can see what the numbers were 1 year later. And it's estimated that by 2020, the US will spend 20% of its GDP on health care. Last year, the US spent $2.7 trillion. That's equivalent to the GDP of France, which is the 5th largest GDP in the world. If we look at the expenditures of some of the other countries, none of them spent half of what the United States did per capita, and none of them spent more than 9% of their GDP on health care. Earlier this year, the Institute of Medicine came out with another damning report showing that the USA was last in treating a lot of common chronic conditions and society problems. So let's turn now to a country that does healthcare pretty well. As you saw in the Commonwealth report, Australia was ranked number 1. Australia has universal health care. Ironically, it's called Medicare. The United States has that also, but it's only available to people over the age of 65. It's supported by an income tax. In addition to Medicare, there are government-owned and private insurance companies. And Australia also supports 150 of the most commonly prescribed drugs. Medical education has to be part of any discussion of universal access to health care. And in Australia, I think they do a very reasonable job. There are approximately 19 medical schools in Australia, and each school has a certain number of so-called bonded positions, and that means that the students in those positions have their tuition supported by the government. It does not exceed $10,000 a year, and in return they go to rural areas or underserved areas once they graduate. In addition, there are 5 different loan schemes for medical students, and there are scholarships for medical students. So you see there's a very elaborate network in Australia where new medical school graduates can go out into underserved communities, and I think that's very important. If we return to the United States, a cautionary tale at best. In evaluating any health system or any population, we need to look at sociologic and psychologic factors as well. In the United States, 16% of the population, or 50 million people, do not have insurance, and access to primary care is often lacking or unaffordable. Despite the higher average income in the U.S., there are also high poverty levels, great income inequality, low rates of social mobility, a failing education system, and this is very important when it comes to educating young people about health. This is probably one of the reasons that the obesity rate in children in the U.S. is 17%. And there's also a paucity of safety net programs. In the U.S., people would rather get in a car to travel 2 blocks to get groceries before they walk. We're also blessed in the U.S. with very stimulating television programming. We have the Kardashians, we have MTV, we have Jersey Shore, and that compels us to spend 5 hours a day in front of the TV. So when you combine little physical activity with abundant calories, the result is a population where 1 out of 3 people is obese. The answer is not to reduce care, but we need to reduce waste, not only in the United States, but in all health systems. We can do that by reducing overtreatment, by reducing care incoordination, lack of execution of proven patient safety systems. We need to reduce administrative complexity. Pricing needs to be transparent and competitive, and we need to reduce fraud and abuse. Finally, let's just discuss medical education in the United States. I see Rula's looking at her watch. Last year, the average college graduate in the United States had a debt of $35,000. The average med school graduate finished with a debt of $180,000. So you can see how a new medical graduate in the U.S., it might not be unusual for him and her to have a debt of $250,000. So I ask you, is that person more likely to go into pediatrics or primary care in an underserved area, or to go into a specialty where they can begin to pay off their debt as quickly as possible? Money has an insidious way of biasing career decisions and medical judgment once somebody becomes a physician, and that needs to be eliminated from the equation. So our goal should be universal access to health care. We need to eliminate waste in existing systems. A direct payment system is a non-starter, and I predict that in the US, probably within 8 to 10 years, it'll go by the wayside. If you look at all of these successful countries, their health care is premised upon a prepayment system. And finally, there needs to be greater support of medical education. And I think this is an area in particular where philanthropy can play a greater role. In conclusion, within the framework of a global welfare society, based upon the collaboration of states, markets, and philanthropic organizations, accessible health care for all citizens is a worthy and attainable goal. Thank you.
Thank you, Dr. Friedman. So we heard from our first two panelists
Thank you.
looked at healthcare
great,
access
great.
on a broader level. And we'll be hearing from the rest of our panelists, both of whom are based in Greece, on their experiences here on the ground in Greece and what accessible healthcare means today here. Thank you. Dr. Koulouvaris.
Thank you very much, Rula, for this kind invitation. So this is a national program from primary healthcare donated by Stavros Niarchos Foundation and provided by Olympic Village Polyclinic in Aegean Sea. This program was created for the underprivileged residents of 35 remote Greek islands of Aegean Sea. Polyclinic Olympic Village is the only Olympic property who is still working after Olympic Games 2004. It has the authority of Health Center and Rehabilitation of Keratea and the authority of General Hospital of Santorini. This is the only clinic in Greece that runs ISO quality standards for the security of information, for the quality of care, and for environmental management. Which is the problem with these 35 remote islands? The permanent population is 60,000 residents. However, during the summer, we have more than 100,000 residents. And the problem is that the shortened distance from these islands is 8 hours by boat, once a week during the winter, twice a week during the summer. At 1 hour by airplane in 3-4 islands with airport. So the longest distance is 24 hours by boat, for instance, Castellorizo. And the best scenario for these people is that there is a small public medical unit with a junior doctor who stays for a year. In some islands, there is a general physician or a dentist. So we have the distance, not easy access. There are few doctors who are eager to work there. They have often complicated medical case. They should take urgent decision, and the help is coming only for Army or Navy helicopters. Our initial approach was to feel and realize the needs. So we talked with the local municipality, we talked with the local doctors. None woman had mammography, none woman of these residents had test pap. We talked with the residents, and finally we talked with the Ministry of Health to know if there is a plan for these people. Unfortunately, there is no a specific plan. They work day after day. There are no doctors to work there. The issues is not only money, but they are not very well confident to work there. Our target population, so were the doctors, the children, the pregnant women, and the adults, finally the elders. There are 4 main areas with aim to help the doctors and the residents. The people with the urgent case, the people with chronic case, and then the preventive medicine service for all ages, and the specialist public health advice. For the urgent case, to help the doctors, we offer them better education, and then we provide them with appropriate medical equipment. What we did, we created a fellowship, 3 months fellowship for these doctors in a very busy emergency department in New York Queens Hospital. They have about 250,000 cases annually. We designed in our needs a fellowship, thanks to Stavros Niarchos Foundation. The doctors, before they set up their service in the islands, they take this fellowship, they have special course, advanced trauma life support course, advanced pediatric life support course, and ultrasound courses. Then we thought the step to the people for primary care, the preventive medicine service, and the public health advice. What we did, 2 ultra-modern mobile clinics are currently built with a generous donation of Stavros Niarchos Foundation. And every 2 months, 5 to 10 days, a health team of 22 persons will visit the islands and will provide primary care. We will provide digital mammography, digital x-rays, ultrasound for all body. Every woman as we know, over 40 years old should have a mammography once annually. We will provide cardiological examination with triplex Holter of blood pressure, Holter of pace, gynecological examination, test pap colposcopy, and we will set up a telemedicine for pregnant with cardiotography. We have neurologists to evaluate the people with memory problems with ANIA at Alzheimer. We will have a very, very well state-of-the-art dental clinic to examine children and adults. We have ophthalmologists with state-of-the-art equipment. We have bone mineral densitometer. We have pediatric examination, respiratory examination, and ENT examinations. We have a dietist with nutrition examinations. We know we have very high obese children. We have health visitors with monitoring of vaccination coverage and detections of congenital disease. In material we provide with presentation in schools for children and parents. The most important point of this is that we have electronic patient record according to ISO. And patients with tertiary care will be staged in Polyclinic with state-of-the-art MRI. Then, if they need hospital, they will be admitted in many university hospitals under our supervision. Heart MRI and breast MRI will be provided by our clinic here in Athens. For this reason, under the donation of Stavros Niarchos Foundation, our doctors are taking now fellowship in Paris and Brussels, cardiologists and radiologists. The electronic medical record will help us not only for research, but we will keep all the records for the patient and we will follow up them. The last but not least, it's with the collaboration with the Department of Education, University of Oxford, we try to create an early learning professional development center for teachers, practitioners, therapists, parents, and school advisors. We will build an online network and we will register all the needs. We will diagnose education and remediation of young children with special needs. It will be mostly for preschools and primary schools. We will support the professional development of teachers with young children with disabilities. I will take the chance to express my great gratitude to our team. All of them are volunteers. All of them are consultants in the highest degree of medical career. Thank you very much for your attention. Thank you very much, Stavros Niarchos, for this. Oh, sorry. No.
Can we switch? Sure. Take your. I will make my presentation interactive. So, dear Urla, I am the last, so I want to make it interactive. So, the majority of the participants in here are Greek speakers. So, I will switch my presentation and I will do it bilingual. You will see the slides in English. I will present in Greek. I give you the opportunity to switch the headphones for the ones that they don't have. Because in PRAKSIS we believe in collaboration. So, we move at a glance, με μια ματιά. Η PRAKSIS είναι...
So, at a glance, PRAKSIS is an independent NGO. It aims to provide humanitarian-focused support in a wide span of fields such as medical, legal, social welfare, psychological and financial support to socially vulnerable groups that are excluded regardless of color, race, religion, age, nationality, ideology, or political beliefs. So PRAKSIS at a glance, it's been operating in Greece for 17 years. It has 31 active humanitarian programs right now, and there are 50,000 beneficiaries per year in the different programs. So how many people do we have working for us? 116 total, and we have 580 volunteers. So health is a human right. So according to the Universal Declaration on Human Rights, the right to health is a conquered human right. So we know that there are various parameters here. For example, the right to access, the right of access to a health system that protects him and where there are equal opportunities so that everyone can enjoy the highest attainable level of health. We're also talking about the right to prevention, the right to treatment, and the right to examination, and also the right to medicines. Of course, the right to health is also a right which includes other factors that can help us say that somebody is living a healthy life. So this person must have access to drinking water, safe drinking water, sanitary conditions. This person must have sufficient food in order to be able to survive. And this person must have a roof over his or her head, work in a healthy working environment. And of course, this person must also have access to public health information. So let's talk a little bit about Greece now. Greece, in this crisis situation, 2 out of 3 households have an annual income which is under 18,000 euro. 31% of the Greek population is facing social exclusion, and they're very close to the poverty threshold. 9 of 10 households have lost their income. So we're talking about jobless households. 1 in 10 households have had an income reduction of up to 60%. 30% earn less than 10,000 euro annually. 80% have been forced to cut down on food, and 60% live on post savings on money they had been able to put aside. 50% are not able to deal with basic needs, be it health needs or education needs for their children, clothing needs, and so on and so forth. 40% owe money to the banks. They are over-indebted, which means that they really can't plan for the future. So the question is the following. Is the right to health an inalienable right in Greece in 2013? So those that have been affected in 2013 and don't have access to the health system are numerous. Those that are outside networks. We're talking about the homeless. We're talking about those who are poor, those who are uninsured, regular or irregular immigrants. Regular because they've lost their jobs, so they don't have health insurance. Greek families which are very close to being evicted. Asylum seekers, people that are in prison, people that are ex-convicts, unaccompanied minors. This is a phenomenon that is on the rise. This is a very difficult subject, and Greece is called upon to deal with this problem, and sometimes we even have to come up with arguments to the European Union, drug users, sex workers, also victims of trafficking, HIV-positive people, and people suffering from STDs, but also people suffering from hepatitis B and C, and also those who are insured, Greek citizens who are insured but who are suffering. They don't have enough money, so they can't afford to buy medicines because sometimes the healthcare organization cannot pay the full cost of the medicines they need. So there's co-payment. They have to pay a certain percentage of the actual cost of the medication. So PRAKSIS is an acronym. We have programs of prevention, intervention, and advocacy. So the word praxis means action in Greek. And what does this actually mean? We're talking about daily action, but also we're talking about mathematical equations. So we are trying to join forces in order to do away with bias, with prejudice, and we want to multiply the support that is given to us by our staff and by our volunteers. So we have three actions as an NGO when it comes to the health sector: prevention, intervention, and advocacy. As regards prevention, so we offer health and hygiene education of children. We also offer shelter to vulnerable groups of the population, people who have suffered, who've been tortured, people with chronic diseases, people who have sought asylum in Greece and who have no way of going back to their countries because they fear for their life. They also fear because there are other problems as well. We also have public health programs. We have programs for HIV, hepatitis B, hepatitis C. So we're talking about awareness raising, but also screening. So we're screening for HIV and hepatitis B and C. We also have free vaccination for children, free vaccination and provision of primary health care to irregular immigrants. So we're talking about people without travel documents. And of course, we also provide support to people who have been found to be HIV seropositive. So we have a program in Thessaloniki. It's called Next Door Children. So these children can come and be trained, educated. They also have access to health care. And in order for us to make this education more attractive, we have a mobile school, which together with ICIS, which is another NGO. So this mobile school is operated in the greater Thessaloniki area. It's a way to attract children. So we offer shelter, as I said, to 206 people. This was the case in 2011, 2012. We rent apartments in Mytilene, Lesvos, in Athens and Thessaloniki in order to meet not just the medical needs of these people, but also their housing needs, because we want them to be able to become active members of society. We also have public health programs. These are targeted. They target population groups which have specific problems, for example, diabetic patients, high-risk groups, intravenous drug users, MSN, men having sex with men, and, of course, people that have been the victims of trafficking, sex workers in Athens and Thessaloniki as well. As regards the hepatitis C test and the HIV test, well, we have a free saliva test. You do this test and the results come out in 20 minutes. We have these mobile units. There's two of them in total. One is in the center of Athens and the other one drives around the rest of Greece, and its headquarters are in Thessaloniki. So in these mobile units, we can examine somebody. We can do pre and post counseling, meaning we can inform him before and after the test, and then we can put him in touch with a national health system. And this is why we consider this test a preventive means. What we don't want to do is to have spreading of HIV infection. In Greece, we have a record high as regards the prevalence of HIV is concerned, but this also applies in the case of STDs. It's 1,580%, particularly among intravenous drug users. That's very high, meaning we have 4 new diagnosed cases per day, whereas the numbers we don't know must be threefold, meaning if we have 4 diagnosed cases, this means that on a daily basis we have 12 new cases of HIV positive individuals. So what do we do with the test? As soon as we find that somebody is HIV positive, and as soon as we link him to the national healthcare system, so we are connected to the Evangelismos unit, these people are immediately start treatment. So even if they have unprotected sex, or even if they don't comply with the prevention measures that are required, for example, contraception, etc., at least when they start treatment, they no longer transmit the disease. This is something we need to do. I'm talking about intravenous drug users because most of the time these people do not comply. They do not show good compliance. Now, something else that in the center of Athens, we want to deal with a very vulnerable group. So we're talking about people that are really suffering. They're immigrants, they don't have travel documents, they're homeless, HIV positive, MSN, meaning men having sex with men. And of course, how many did I mention? There's going to be 6 people who have 6 things. So I said MSM, HIV, homeless, immigrants, intravenous drug users, and without travel documents. So those are the 6 problems these people are faced with. So they're a high-risk group, and it's very difficult for these people to be treated. I know Rula's going to have a heart attack, so I'm going to go faster. Now, as far as HIV positive individuals are concerned, because they're a vulnerable group, we have a specialized service. We receive their requests. We try to give them treatment, but we also try to get them travel documents, particularly for those who are from countries where we must prove to the Greek state that even if they do return to their home country, they won't be able to be treated. And I hear the MACH Foundation is funding this treatment. And I'd like to say that we now have a pediatrician department in our Polyclinic in Athens, and we offer vaccination in Athens and Thessaloniki together with the NGO Apostoly Anthropos. We also offer primary health care to immigrants at the border. This is a mobile support unit. It goes from Promachonas all the way to Evros. The second one is going around the Aegean Islands. So we're trying to offer health care to people illegally entering Greece before they're arrested by the police or by the Coast Guard.
About intervention. About access, we offer access to healthcare in 2 polyclinic centers with general practitioner, gynecologist, ophthalmologist, and dentist. And I have to say that dental care in Greece, particularly during the period of crisis, is something that Greeks, not even Greek, can have access to. For Greeks, I will really say the following. They go to the dentist and they ask the dentist to whether they can pay afterwards and repay their debt on installments in a way. We serve 30,000 people in our multi-clinics from 35 different countries. It is a crossroads, rather a melting pot of cultures. They have free access to care and medication. We actually collect medication from our fellow citizens. In general, Greek people love taking medicines, and they bring in medicines that they don't use anymore. We carry out our control, a quality control on this medication, and we offer them to these people. We have made a calculation, and it would have cost 700,000 euro if we were to buy such medicines to cover population needs. As regards access to health care, in the open day centers we have, this is something which is financed by Stavros Niarchos Foundation. We offer primary care to homeless people, and this primary care is offered through the street work we carry out. That is, social workers go out in the streets and we offer assistance, health care services on the spot. We also invite these people to our premises where we offer primary care. We always talk about primary care. We also have some secondary care. We refer them, we have referrals, we refer them to various hospitals. We have concluded some sort of partnership with state hospitals, with doctors who really want to offer their services free of charge, in a way violating the law, because the law actually forbids this. We have our hidden tacit agreement, and this is actually We should acknowledge them for that, but in this way they manage to help other people. As regards unaccompanied minors, we have a center in the city of Patras. We offer primary care there, hygiene services. In addition to the services, we offer the healthcare services for unaccompanied, unescorted minors. In Greece, 5,000 unaccompanied minors come to Greece, because this is a long course that starts in the city of Patras. Then these people get to Italy and Calais and then to other European countries. This is a triple trafficking: sexual exploitation, trade of organs, and slavery. We also offer healthcare services to people who are out of prison, because the system cannot afford to, people who are out of penitentiary institutions. These people are excluded a priori. As regards advocacy, Rula, be patient. PRAKSIS is trying to establish, create networks and participates in networks. In this way, we try to do both advocacy and lobbying. We try to set the scene at European and national level, to put pressure on the Greek state to change policies, to open up to new population groups that are excluded by now, not being recognized so far. Homeless people do not exist in Greece. We put pressure, and it was voted in a multi-bill before the closure of the parliament, before the last elections. We voted for the sort of enshrinement in the law and the establishment of the category of homeless people. We built bridges of cooperation. PRAKSIS is funded by the private sector by 85%, by foundations, by corporate social responsibility, and also it has subscribers. The rest comes from European programs. We are not a body of general governance. We don't get money from the state budget. We decline any such negotiation at this moment. We try to preserve our independence. And not only this, but also we believe that we should create a sufficient legislative framework that would be able to evaluate the government work and the legislative work in order to be able to offer services, such services that will be governed by transparency, effectiveness, ensuring access to vulnerable population. Children from the private school Kosteas Gitonas created an application called My Pharmacy. This is an application they promote in order to collect drugs for PRAKSIS, so that we can offer such drugs free of charge to people who need it, who need them. We also cooperate with the SMOS NGO for dental care for children, and we have this NGO found volunteer dentists. We try to promote corporate social responsibility programs, and also we invite individuals, subscribers, potential subscribers, to finance and to offer their assistance to PRAKSIS in order to maximize benefit to vulnerable population. Okay, no more examples. We cooperate with international organizations like the all the ones that you can see on the transparency, and you can see the foundations that provide financing to us. Thank you very much for your attention.
Thank you, Tzanetos. Sorry to be the bad guy, but I'm the timekeeper of our group. We have only a few minutes. I know most of you were here for the entire session, so you got to hear some of the commonalities in the challenges of access to healthcare, even though everybody spoke about something different. So it's not only a matter of the lack of availability of doctors or supplies or hospitals, but there are plenty of social aspects to affecting access to healthcare, including geographic barriers, cultural barriers, financial barriers, socioeconomic status. Now, the other common thing we heard was that providing access to care means going down into the community, understanding those needs, working with the community to find those needs, and building in some solutions to create that access, whether it's through the medical education system and making sure doctors are out in rural areas, or plain and simple, understanding what the services are needed, what kinds of services are needed, and what kinds of capabilities there are on the ground in Africa or even the islands of Greece. So I'm going to start with one question and then just begin taking questions from all of you. One thing we're all aware of is that most of the funds flowing in the healthcare sector come from the public sector of, or even the private sector of the model that Anders Asland outlined for us in the social welfare society. The philanthropic sector and the funding there is only a very small portion. How impactful can that philanthropic contribution be to changing access to healthcare? I'll let any of you take that question and provide an example, and then we'll open up to questions.
Thank you. That struck me about what Professor Aslan said was one of the greatest opportunities for philanthropy is with higher education. And I wasn't sure if he meant high school or college, but what occurred to me is if he wants to go one step better and incorporate graduate medical education as well, I think that's an area where a huge impact could be made. I think medical education needs to be reformed. It needs not to be so expensive. And we need systems around the world where medical students know that once they graduate, they will be working for some time in an underserved area. That just has to be part of the deal. So.
Anyone else on the panel? Dr. Barber? Oh, Dr. Koulouvaris.
Yeah. Thank you. Actually, talking with the Ministry of Health regarding the islands, there is no any, as I mentioned before, there is no any specific plan for these residents. They work day after day, nothing for the near future. So the philanthropic role now has a tremendous impact for these people, and not for the today, but for the future, for their children.
Αυτό που έχουμε παρατηρήσει γενικά στην Ελλάδα, δεν υπάρχει μία.
So what we've noted in Greece that there is no long-term strategy in place. So we're talking about passive policies that have no active role to play whatsoever, particularly at a time like this, meaning where the crisis is becoming deeper. So what we see is just cuts without there being any prior evaluation on people who are at risk, areas that have been more like ghettos, areas that are remote. So there's no assessment. We know that people's needs are increasing all the time, and we see that this crisis has led to many social movements that are informal in nature. And let me just give you an example. We have social groceries opening up all over Greece. There are 220 social groceries in Greece that have no legal status. What does this mean? This means that there is no framework within which they operate to provide food. So we in PRAKSIS conducted a survey. So we looked at 50% of these social groceries, and we saw that the food that is available through these groceries will force us to actually have programs for diabetes and cardiovascular diseases, because the food available through these groceries, these social groceries, are high risk. This is another impact of the crisis. We need to look into this very carefully. So the government must do something about it. I think they need to look into it and take action.
think it was a very nice analogy in the session earlier about the swimming pool in the Mediterranean. I think, the philanthropy has to be very mindful about where they would put their money for maximum effect. And I think there is a big opportunity that philanthropists have to demonstrate a better way of doing what the mainstream health system is trying to do. So investing in opportunities, innovation opportunities, where you can really show that you can get a great result, take that result to the main health system and say, here's a much better way to do it. It's all really about implementing what we know.
Anyone have questions? I guess we'll start here and move our way across. Dr.
What can philanthropy do to stem the tide of professional exodus from underworld countries, like especially in Africa, where you have 60,000 professionals leaving in 10 years? You talk about graduate medical education. That's true, but how can you keep them there? And what's the role of philanthropy in stopping it?
I think there are some really good examples of programs that have tried to address this very specific problem. I can think of the Fulbright system in the United States, and the the MEPI system that is run by USAID. The philosophy there is that they will only provide support for physicians and nurses who have a commitment to stay in their own country. I think that's the one thing. The other is there's a huge responsibility, I think, on the part of European and North American countries to not provide permanent work opportunities for people where those other countries have expended tremendous amounts of money in training those practitioners. Now that's very controversial, because you would say that people should have the right to go and live and work wherever they want. But I think you're correct. There is such a tremendous issue. On the other hand, there are countries like Ghana and Nigeria now that are actually attracting their expats back with great opportunities in those countries.
Great. And we'll move to the gentleman and the lady in the front.
Vangelis Kyriakidis from
My name is
Conservancy. I just wanted to refine a little bit on the observations you made about education and philanthropy earlier. If you look at the medical schools of most of the American universities, they are very well endowed. In fact, most of the medical schools probably attract much more funding than any other school in a US university. So this is not really a lack of funding towards medical education in the university level. What I would think perhaps we could take away from this discussion is that foundations should be pressurized, or perhaps they should pressurize the people asking for money to be giving the money towards the right direction, cheaper education or free education for the underprivileged. Rephrasing again, more money, but for the right direction in medicine and medical education. And that also applies to strategy. Very often we see a lack of strategy in the part of states, but we also see a strategy in the world of foundations. So for example, a specialized foundation, or a foundation that has 5 causes, but each one of them has got specific outcomes for each cause, is probably a way forward for what we want to achieve. So strategy is obviously very, very important, and very important in all levels, from the NGO level to the state level to the philanthropy level. And so more strategy, more directed donations for the right causes, and experienced people like yourselves may very well point out which are the causes, specialized causes that would make the greatest impact.
Anyone have a comment? Dr. Friedman?
Yeah, I think you made a few excellent points. And basically what you're saying is there are situations where money isn't the problem, but where is the money going? And there are universities, I won't name one.
Which is microphone.
Microphone.
I'm sorry. There are universities in the United States. One I'm thinking of has an endowment of about $20 billion, and next year their medical school tuition will be $6. So that's a conversation that's just starting in the United States, but that money shouldn't be sitting in bank accounts. It's got to go towards exactly what you said.
Next question.
Yes. First of all, I want very much to thank Mr. Antypas for having presented my pharmacy project, which I will very happy to present tomorrow. That was a project which came out with the Virtual Prize, which is a junior achievement activity in schools. But thank you very much for that. I have two questions. One for Greek speakers and the other for the whole panel. The Greek speakers, both of you have projects in the islands. Do you cooperate there? Do you share experiences and facilities, for instance, addressing issues of children, of non-accompanied children on the Cyclades? Do you cooperate there, or do you have some separate activities? So the first question. And the second question to the whole panel is the following. It seems that at least in Southern Europe, we get another weak group of people, which doesn't seem to be very weak. Those are the young unemployed. The young, long-term unemployed. It seems that they will stay unemployed, or they will become long-term unemployed. Are you aware of any model that is preventing these people to be not covered by healthcare? Because normally, if they just finish school, and if they just finish high school and do not find an employment, they're not insured. Does that mean that they should not have healthcare? I mean, are you aware of any model addressing this problem?
Concerning the first one, τώρα θα το πάρω, πώς θα θέλετε να απαντήσω, στα ελληνικά. Okay. Concerning, σύμφωνα με το πρώτο που λέτε.
Concerning the first question, there is a networking and cooperation in order to avoid overlapping. We should also see the intervention models. On the one hand, we have to do with remote areas and population not having access to specific medical residencies and PRAKSIS or specialties. And PRAKSIS offers primary care to the islands for immigrants, illegal immigrants. So there is no overlapping. Of course, there is networking in order to be able to actually refer cases one to the other and coordinate in order to avoid overlapping. This is the first thing. As regards your second part, in Greece, we have a new phenomenon. Young people, none in education, in employment and training skills, needs. Off the microphone. The speaker is off the microphone. The lady from the audience is not on the mic.
Even.
If they would come into education, they would come into position.
Okay.
Excuse me, I mentioned the young generation,
Okay.
which is educated, which is ready to work, is willing to work, and does not find any work. And we have some 17 to 18 millions only Southern Europe.
For the,
Okay. What does happen to them?
Γι' αυτό στην Ελλάδα υπάρχει μια πρόταση.
This is why there is prevention in Greece. They can be considered as uninsured. They can be under the welfare system. They will have this booklet for uninsured people, and they can have access to any hospital in order to, and they can also get their drugs from the hospital dispensaries. Of course, some red tape procedures are involved there. For a person to issue such an insurance booklet, you need 2.5 up to 3 months in order to be able to get it.
Solved in the States?
I'm not aware of any good solutions or models. It's a good question.
The only short answer is that under Obamacare, the children will continue to be insured up to the age of 26. So that was an advance, so that the children stayed on their parents, whether they were working or at college or not. So anyone up to the age of 26 is allowed to stay on the parents' insurance. But beyond that, there is a, if they are destitute and poor, then they can get Medicaid, state assistance, but it's not a good situation if you're in between.
Yeah, thank you. Well, we'll take a question from the front here.
My name is Dimitrios Linos. I'm a surgeon. I would like to ask Dr. Koulouvaris how many of his physicians that will be dedicating their lives to the 35 islands, 60,000 people, have taken this opportunity of spending 3 months in the US, their expenses be covered by the Niarchos Foundation. What is the number?
Actually, it's very pity to say that there are not many doctors that are
Just
in
answer, 1, 2, 0. Because I know the answer.
Actually, for GP, we have 5.
Okay.
But
there's a different situation between the States, Ghana, and Greece. We have serious problem, The education, the medical education in Greece is 0. Families pay no money. But there's a different attitude. So I know that because as president of the American College of Surgeons, we offer through the Niarchos Foundation another scholarship, specifically for Greek surgeons. And no one is applying. I have to just drag. And so we have to say the local problems and try to save the local problems. Also, the other thing is, I'm not going to ask the second question, how many women you have examined and did the mammography, because you say you will do that. So the question is, try to focus on a small, tiny thing, one thing, and cooperate. There are hundreds of very nice Greek doctors and organizations that aim and have tried in the past the same goal. So, and I suppose from what we heard, this is a problem from all the NGOs around the world. We cannot in this small country, each of us, just stay within his or her own scope. We have to cooperate, and I think this is the main message of this meeting. Thank you.
Thank you. We don't have time for any more questions. We have to prepare to move to the next panel. I did, though, if you can answer maybe with a word or two. Most of us think of the philanthropic sector as the group that will bring money to the table. Is there something, in your opinion, really short answer, that you think the philanthropic sector could bring to the table outside of funds? And we'll close the session with that. Thank you very much for attending, and we'll see you upstairs in the plenary session.
So my single answer, I would respond to the gentleman by saying one of the most important things that funders can do is to bring outside NGOs together to cooperate. I think it's a crucial role that the funders have.
Thank you, Dr. Berger. Short.
I was inspired from what Mr. I don't know your name, said concerning networking. Αυτό που λέμε πάντοτε.
So what we always say in PRAKSIS is that we're alone in the world, particularly now in the crisis. So now that we are alone, we have to be on each other's side. We have to help one another. We have to join hands. And sometimes if we work together, sometimes we don't feel good because we lose our status, a status of authority, because we like working on our own. But sometimes if we start working together, we'll be rewarded by the fact that we'll be in good company. Thank you very much.
Maybe 5 words. Efficient organization, manpower, without the constraints of government.
Thank you.